the other tests we might see in labor and delivery. Number one, I want to point out that in your Facebook page, this website is also posted, but there's some great information on the playlist. If you go to MDCCC Nursing, go to the YouTube, go to MCH Antepartum and the playlist, and there's some good videos for you to watch and give you some more information. The other thing is he's broken down to understand term and preterm, and included the fact that even term, a stillborn is going to count under term. Okay, so if the pregnancy went to term, you're going to still include that in the T for term. There are also 2 different P's in the GTPAL. So you may not even have to worry about parity, because I don't think they include it on Thursday. Okay? So we may have gone through all that for nothing. But if you're in labor and delivery, you need to know parity. Okay? But I don't think they do include that in this information. So what are some of the other tests we might see in the pregnant patient? A non-stress test. And you need to know what a non-stress test is. NST. Non-stress test. So a non-stress test as well as a CST, contraction stress test. A non-stress test is that we're monitoring the baby for at least 30 to 60 minutes, sometimes longer, without any stress. So think of stress as contractions. Okay? So we're actually seeing how the baby's doing without contractions. And what are we really trying to find out? If the environment inside is okay to continue the pregnancy. Okay? So we're seeing if the baby is doing okay in utero. A contraction stress test we usually do if we're concerned about a patient and how the baby might handle labor. So we might do a contraction stress test. Again, it's usually 30 minutes to an hour. And we're trying to see if the baby is doing what it needs to do during those times. Okay? What type of patient might need a non-stress test or a contraction stress test? High-risk pregnancies, especially who? Preeclampsia and diabetics. Guys, I always think of young people, especially pediatrics, as a clean slate. You know, it's a clean slate. Well, a diabetic mom, that placenta ages very fast. And think of the placenta as the baby's only connection to life. Okay, that placenta and that cord. So you might have some calcifications. Now, who else? Drug addicted moms? Nicotine use? If you ever see a placenta of a mom who smoked, you can see nicotine deposits in the placenta. I know. It's a filter. That is a filter to protect that baby and everything that goes through it. Now, someone who has a high-fat diet will have fat deposits in their placenta. Can you see how those things can affect the circulation to the baby? Absolutely. And I want you to think about this as a for our moms who are smoking, so that you can educate them on it. Babies, the only way for lung maturity to occur in utero is a baby actually practices breathing. And they're breathing in the amniotic fluid. Isn't that cool? They breathe in the amniotic fluid and then blow it out. And this is closer to term, okay? It occurs right around 32 weeks where they'll start practicing. And this helps in their lung maturity. And they're actually breathing in amniotic fluid. For every puff of smoke, a baby will quit doing that for an hour. Puff of smoke. I'm not talking about a whole cigarette. I'm talking about a puff of smoke. And that includes secondhand smoke. So can you imagine, now you understand why smoker babies tend to have more lung problems? Because they don't have that potential for lung maturity, because for every puff of smoke, they're not doing that practice. And that's been documented. So again, we want to make sure they know. Now, what about amniocentesis? When might we see an amniocentesis in pregnancy? And why would we want one? And an amniocentesis would include like cord sampling. Anytime we need to get into mom's abdomen to the baby. Okay, when might we see that?
Chromosome, like they might have chromosome.
A genetic disorder. So it is a confirmative. Like we can go and take amniotic fluid from from inside and test it for things. Okay, such as abnormalities, DNA abnormalities in chromosomes, diabetes, other disorders.
Meconium.
What else?
Meconium in the fluid.
Okay, so we can see meconium. We're not going to do an amnio for that, because is meconium in the fluid a problem before the baby delivers?
Yeah, because
No, it's not.
Okay.
Before the baby delivers, no. Okay,
During delivery.
when the baby delivers, it's a problem that they pooped in their amniotic fluid. Okay? And I want you to know what that means. Okay? So when we become hypoxic and die, our bowels release. So what happens? How do you think meconium gets in there? That's what happens to the baby. It had a hypoxic event at some point and expelled its bowels. Are y'all with me? So that kind of changes how you think about meconium, right? It's not the meconium that's the problem. It's the fact that it had a hypoxic event. Now, we don't always know when it occurs. So if it occurs a month before delivery, and there was no neurological effects from that hypoxic event, recovered well, no big deal, that meconium is not a problem, because guess what? The placenta is continuously cleaning and filtering, and the baby actually takes it into the, not only sucks it into its lungs, but it also takes it through its digestive system and pees out. So there's urine in that amniotic fluid. Did y'all know that?
So the baby eats the food.
So the baby eats, that's, it's practicing, okay? There's no nutrition to it, there's no anything to it, but its kidneys are working. That's how we know. So when there's not a lot of amniotic fluid in mom's uterus, it's because of one of two things. Either the placenta is not working well enough to replace the amniotic fluid, or the baby's not peeing it out, meaning there is a problem in the GU system from the waist down. When there's too much fluid, okay, and that's oligohydramnios, or poly is too low, or is it?
Too many.
It's the opposite, sorry. Polyhydramnios is too much, oligo is too low. So if it's too low, that means either the placenta is not working well, or the baby's got a problem in the urinary system.
So it could be kidneys, bladder.
It could be kidneys, it could be bladder, it could be
Urethra.
anything, urethra, anything, okay? If there's too much fluid, it's either usually, because the placenta is not going to overproduce, it's usually that the baby has a upper GI problem. Okay? It's not keeping it in. So then it just builds up. Okay?
Is it possible
As well
for
as
it to take
diabetes
it
would
in
do.
and regurgitate it?
No, not usually, because it's not going to there's not going to be a malfunction in the baby. So, that would take a problem unless there is a blockage. I mean, again, it could be, but it's usually that it's not going through. It's from the stomach up. Okay? So that's how we identify those things. Now, why would you want to do an amniocentesis prior to 20 weeks?
To prevent miscarriage. 'Cause
Okay.
they, run out of room, maybe.
Not necessarily, because again, genetics hasn't kicked in. The baby's usually the same size for everybody at that age. So why would you want to know? Maybe a definitive to decide termination for mom. Okay? Now remember, there's not a lot of amniotic fluid before 20 weeks. So if you ever need an ultrasound, a pregnant mom needs an ultrasound or an amniocentesis that is ultrasound driven, then you have to have fluid to look through. Ultrasound only works with fluid. So what do we need? Full bladder. If it's past 20 weeks, do we want a full bladder?
No.
No, because we could potentially cause a problem. So we want an empty bladder. Okay? So, any questions about any other test? Any other tests y'all want to go over?
But with amniotic fluid, I don't they rarely do that now. They just give you the MS. That pour a lot of things.
I had an amniotic because that was a geriatric pregnancy.
Right.
Anybody
Anybody over 35 is high risk because you're considered advanced maternal age.
I said he could say that one time.
I don't even know. He may have been messing with you because I don't know that anybody's ever really called it that. We just call it advanced maternal age, but you must have had a good relationship with your doctor. So, there are other advancements, but we're still doing amniocentesis. We are still doing amniocentesis, and I don't know that we'll ever, because there's some things you just can't. Now, preterm, I don't know that we're doing that many amnios because there's so much risk to an amniocentesis, guys. It's a needle going into mom's belly, having to avoid the baby. Because if that needle nicks the baby, it is a huge big deal. How do you make a baby behave? So, I mean, honestly. So, it's a huge big deal to do an amniocentesis. So, there has to be a good reason to do it. And again, I don't know that we're doing a whole lot before 20 weeks anymore because of that reason, because we can identify a lot of risks ahead of time that we would terminate for. So, but you need to know it. Okay? That's all I'm saying about
Need to know what?
Coombs. We're gonna when it comes. We're gonna go over Coombs because that's real important. You're not gonna see Coombs test in mom, but I want you to make sure we go over it before the end of the day because Coombs becomes very important after delivery. And who are we testing for Coombs? The baby. We do it on cord blood. Okay? And remember, cord blood is whose blood?
Baby.
The baby's blood. Okay? So, you're working in a little, let's see, hold on. Oh, I think it goes through a lot of the same things and then goes to part 2. Unless it started over.
I think it's something over.
Okay, here we go. Okay. So, Sim Mom has come in labor. She's in labor. She's 8 90% -1 and her membranes are intact. What does that mean?
90%.
Okay, what? And her water hasn't broke. Membranes are intact. Okay.
What does the -1 mean?
Okay, so you remember the ischiospines in the, that's zero station? -1 is 1 centimeter above.
Okay.
Okay, so it's the relationship of the presenting part to mom's pelvis, the ischiospines.
And they can go up to 3.
It can go up to -3. Above -3 is ballotable. When it goes plus, that means the presenting part is starting to go beyond, okay? And usually by +4, I've seen +4 written, okay, but usually beyond +4 is crowning. We can see the baby's head coming out. It's not out, but it's crowning, okay? But I've seen somebody actually write +4. I guess their centimeter's a little different than mine. So again, +1 is a centimeter past the ischiospines, 2, 3, and usually after 3 is crowning, meaning we can see the baby's head coming through the skin, past the vagina. So the mom is 8 centimeters, 90% of face, -1 station. Okay, so the cervix, I want you to think of it like this. This is the cervix inside. It's long, okay? It's usually pretty firm, and it's closed. Now, for a first-time mom, it's more closed than after you've had a baby. Okay, so once it opens, it never quite goes back to where it was before. So usually, and again, guys, I don't want you to get caught up on what a centimeter means versus, but the centimeters is how open it is. The effacement is the percentage of thinning. So as the cervix opens, it starts thinning, okay, to where it's 100% thin. And then now you're only going by how many centimeters it's open. Okay? So it's how many centimeters it's open, the thinning of the cervix, and the station of the baby. So, what you think?
She's pretty close.
Right. 10 centimeters is complete. We can't push or attempt to push until someone's 10 centimeters. 10 centimeters means that I don't feel any more contraction. Cervix. The cervix has gone all the way behind the baby's head, and I can't feel it anymore. Now, can you see a problem if you start pushing and you still have a little bit of cervix there?
Mm-hmm.
What's the problem? You can tear it, or actually tearing's not the worst thing.
You could choke the baby.
What?
Choke the baby.
No, it can swell. You've just set your patient up for a C-section because you can't get rid of swelling. You can't make the swelling go away. If we start pushing against a cervix that's still there and it swells, she'll never deliver through that. Okay? So again, we don't want her to push until she's completely dilated. What stage of labor is she in? Okay, so now we have to talk about labor stages. She's more in later stages of labor, but we need to talk about the other stages of labor because it's very important. You have, what is that? Okay. So you have different stages of labor, and then in the first stage of labor, you have different phases of that stage. Okay? She's still in stage 1 of labor, because she hasn't delivered. Okay? So stage 1 is from the beginning of labor until what? She is complete.
Complete dilation.
Completely dilated. There are different phases of that stage, and that is latent, active,
Transition.
transition.
So from beginning of labor until completion of dilation?
The beginning, right, the first stage of labor is from the beginning of labor to complete dilation. Okay? There are 3 different phases of the first stage of labor. So latent is the early stage where she's probably still excited to be here. Okay, and she's talkative. She might be more conversational. If she's at home, she might be cleaning the house and what we call nesting. Okay, it really does happen. And that goes to from 1 to how many centimeters dilated?
4.
Oh, 3.
To 3. Okay? To about 3 centimeters dilated. Okay? That's the latent phase. The active phase, things get a little more serious. Okay? So she's not as talkative. She might be really grumpy, and usually she really takes it out on her husband. Okay?
You did this to me.
That's it. So it goes from 4 centimeters to what?
7.
7 centimeters. Okay? The transitional phase, guys, I can see a woman walking down the hall and usually tell when she's 8 centimeters just by the attitude, except for cultural differences. And I'm telling you, there are 2 cultural, really one culture that like you can't tell. They will be popping out babies. Asians. They will be popping out babies, and you think they're not even in labor. It's amazing. Okay? It's the only culture. However, Hispanic women are very stoic and usually don't want any pain medicine. Part of it is a cultural thing. And so, very stoic. Sorry, Caucasians, they just want their epidural at 1 centimeter. They do. I'm telling you. So anyway, and part of it is just, what they're prepared for. So, you have to know the phases and stages of labor. So the second stage of labor is from the time she's complete until the baby delivers. Okay? So until the baby delivers, we are not, if she's truly actively pushing, now because of these wonderful things called epidurals, just because she's complete doesn't mean we're going to go push. We let them labor down, which is really, I want lunch, and the doctor's not coming till 3, so she's going to labor down for 3 hours, not quite like that. But we don't have to rush. Just because she's complete doesn't mean she has to deliver. Now, if you have somebody who doesn't have an epidural,
They're going to do that right now.
you are not letting her labor down, I guarantee you. So, again, that matters too. The third stage of labor is from the time the baby delivers until the placenta delivers. And the final stage of labor is after the placenta delivers for 1 to 2 hours of the recovery period of mom. She's still in a phase of labor. But of course, we have 10 other patients we need to get on postpartum, but there's a lot of risk that goes on not watching these moms closely. So again, that's gonna be when she's most at risk for postpartum hemorrhage.
You said
Yes.
delivery of the placenta till when?
1 to 2 hours
1 to
after.
2 hours after delivery, into her recovery. Okay? We talked about fetal heart tones and contractions. Keep in mind that, and again, when we do fetal monitoring, we're going to go into it a little more. But there's an external and an internal fetal monitoring. We're going to go over it again, make sure I do. Other labs that we're going to get on, Tim mom came in, she's 8 centimeters. What does she want? Her epidural. What does she care about? Her epidural. Okay? What do we need to do to keep her safe?
Give her epidural.
Yeah.
It's too late at
So
10.
there's a cut. It's not.
It's not?
And so we're going to talk about that. It is
Lying
never too
fools.
late unless the baby comes out, but they will lie to you.
Yeah,
I
she
guarantee
said
it.
lying to me.
Now, what we do need to do
about to cuss
though
out your
is I can't get her an epidural right now. She just walked in. Okay. Number one, I have 2 patients, and I have to remember I have 2 patients. So I have to assess both. And the only way to assess the baby is fetal heart tone. So what is a priority in labor and delivery?
Fetal heart tone.
Fetal heart tones. Fetal assessment. Okay, not just getting fetal heart tones, but fetal assessment is a priority to our patient. So what's our next priority?
Mama.
Mom. And so what are we assessing mom for? What do we need to assess mom for as a priority?
Her oxygen.
Okay? So we need to get her vitals. Okay? We need to make sure we know her vitals. Okay? So we're going to give her vitals. Vitals are a priority, but again, she's walking, talking, you know, she's pretty stable. We can tell she's breathing. We can tell she's well oxygenated. If we have good fetal heart tones, do we know she's well oxygenated?
Mm-hmm.
Yes, because her oxygenation is what's supporting that baby. Okay? So, but we need to do an assessment which does include vital signs. And so we get her vital signs. And why is blood pressure so important in pregnancy?
Because it could, yeah.
Because it is a symptom of preeclampsia if it goes up. It is not preeclampsia. Okay? And we're going to talk about that. But it is a symptom of preeclampsia. What are some other symptoms of preeclampsia?
Edema.
Headache,
Edema.
proteinuria, edema. Seizures is eclampsia. Okay? So, eclampsia, which is really what we're worried about, right? Preeclampsia is the precursor to eclampsia, and eclampsia by definition is seizures. So what we're really assessing for is her likelihood to have a seizure because of pregnancy, and pregnancy is the problem. It's actually the placenta that causes her to be at risk for preeclampsia. So what is the only real treatment for preeclampsia?
Delivery.
Delivery. You get rid of the placenta, you get rid of the preeclampsia potential, the hormone. Except it kind of hangs around
For a while.
for how long?
48 hours. Or is it?
No, they have to be on
Magnesium.
Huh?
I think it says 6 weeks, 6 to 8 weeks.
For at least 2 weeks. The first 2 weeks are the worst, but up to 6 to 8 weeks. So guess when they're really still at risk for preeclampsia?
When they go home.
Postpartum and home. So we need, just because she's not preeclamptic right now, doesn't mean that she's not going to go home and have a seizure just because she was pregnant.
Why does that happen?
Because of the hormone that is given off in the placenta. Now what we don't know is why you and not you. Why you and not you. We don't know that. And they've tried to study everything. There was a study way back whenever I was having kids that it was iron in the pan, so then we couldn't fry in the iron skillets. No. Didn't make a difference in preeclampsia. So we were still having patients with preeclampsia. We don't know why one person and not another. What we do know is that if you're a young mom or a not geriatric mom, advanced maternal age, that you are at higher risk for preeclampsia. We know that if your mom had it, you have a better chance of having it. If your sister had it, you have a better chance of having it. We also know if you had it before, you have a better chance of having it. And if you're diabetic, you have a chance of having it. That's all we know. That's the best we can do.
So having hypertension before you have a baby?
Having a pre-existing condition absolutely puts you at risk. Yes, especially hypertension, but really any pre-existing condition, such as diabetes
They
or.
usually get 48 magnesium. 48
So,
hours.
yes.
Okay, it's only 24.
So it does put you at risk. Now again, how do you differentiate from hypertension and preeclampsia? It's all the other symptoms. Remember, it's a syndrome. What is a syndrome? A collection of symptoms, right? A collection of symptoms, and those are the symptoms. It is your elevated blood pressure, your swelling, headache, as just not feeling right in the head, okay? I know my coworker's by first name, and I'm not going to give her first name, but she told me I can use that. She was preeclamptic, and she just didn't feel right in the head. She had no elevated blood pressure. She had no other symptoms. She just didn't feel right in the head. So just abnormal, because what happens in preeclampsia is the blood vessels are spazzing, and it allows things to move across that shouldn't move. Thus, protein, fluid. Okay, so you have fluid in the tissue instead of in the blood vessels. So when that shift happens, you think it's not happening in the brain? So that's where your neurological symptoms come in. Okay, so it's this muscle or this vessel spasm that's going on in preeclampsia that causes all of this. So, what's another one that we didn't talk about?
What about your sodium levels?
No relationship. No relationship. It's the protein that spills. Obviously, you might have some shifting because of fluid shifting. So,
Listen to preview. Is
is
that the other one?
Nope. Nope. Now, what's another symptom that we have to check for?
Oh.
What is it? I gave you all this bill.
I know.
Increased deep tendon reflexes.
Oh, yeah.
So,
I remember
does
that.
anybody really know how to do a deep tendon reflex? Okay, I need a volunteer. Come on. You want to get my bag, don't you? And that's good, because I have to sit on the table on both sides. I'm going to demonstrate how to do a deep tendon reflex. Because most students get to this point and they're like, never did. Like, on top of the fact that, guys, do y'all know what your normal blood pressure is?
Yeah.
Do you? What
No.
is it?
118/74.
Good. Who said yes? What's your normal blood pressure?
Usually 105 or 80.
Okay. Is that 120/80? No. So can this be hypertension for a patient? You have to know they're
They're normal.
normal. So where are you going to find her normal?
Ask her.
Where at in her chart? Where at?
History.
Which visit? Pre-pregnant visit. That first visit. That first visit. That's what you're going to compare that to, because all the other ones are in the disease of pregnancy, right? So you need to go back to her pre-pregnant blood pressure and compare that to it. Because what if her pre-pregnant blood pressure was 90 over 60. Is she hypertensive?
Mm-hmm.
It's 10% above the normal. That's 10%. That's more than 10%. She is hypertensive at 110 over 75. Okay? Now, the rest of y'all need to go find out what your normal blood pressure is, because if we expect our patients to be responsible for their care, then we better demonstrate it. So we need to all know our normal blood pressure, okay? Now, when I'm doing deep tendon reflexes, don't get caught up on the arms, okay? It doesn't matter. If they're hyperreflexic in one, they're hyperreflexic, okay? It's a problem. So I don't even have to do both legs, but I need to do one, okay? So, you can have a hammer, that'd be great. I don't carry one in my pocket, and you probably won't either. So what I'm doing is I'm finding that space right here, okay? We're gonna do it on the other side so y'all can see. And I'm gonna take my hand right here. So, is that normal? What would you call that? So we can't just say normal reflexia because the severity matters. So how are we going to document that? Nope. How are we going to document what y'all just saw? Y'all can't say because y'all didn't see it. Very good. 2+. We're not going to put normal. We're going to put 2+ because the difference between 3+ and 4+ matters. And it would be, and it is bad. Mm-hmm. What's that? If they don't have one, that does happen. And so, hopefully, if you ever were hyperreflexic, you would. It's okay if you don't get it, as long as you know you did it right. You try to see, so you can do a different area. So I'd do an arm or, something else in the other leg. Okay? But if you get a 1+, that's okay.
Pinch the back of your arm.
Okay? But I'm going to document 1+. Because again, what if I have to put her on magnesium and hyperreflexia wasn't one of her symptoms of being elevated? And I get 1+ again, well that's not, it didn't go down. It was the same for her. And because that's a sign of having too much mag, being toxic on mag, is when your reflexes go down, okay? The other thing we're gonna check is clonus. So does anybody know what clonus is? So clonus is a spasticity in the foot. So in order to do clonus on someone, we actually take their foot, we twist it like this, and I pull back, and if it goes like this, they're positive clonus. That's a very bad thing. It's a later sign of someone being close to being to the threshold of seizure, a positive clonus. Okay, so you're going to be doing your reflexes, you're going to be doing clonus. So switch sides so that they can see. Would anybody like to come and try to do a reflex on her? Since I demonstrated it? You have a hammer?
If I have one, I would.
Use your phone.
You really don't even have to have a hammer, guys. Okay, so all I'm doing is I'm finding that notch. Okay, I'm finding that notch, and I'm hitting.
So what happens if it's like,
Anything over 2+ is hyperreflexia. Ding! One more sign of preeclampsia. Now again, if that's the only thing you have,
then?
it's not preeclampsia. Because you have to have at least 2 symptoms. What are the 2 primary symptoms?
High blood
Blood
pressure.
pressure and
Protein.
proteinuria. And edema. But those are the 2 main things. But don't most pregnant women get real swollen?
Yeah.
Did y'all get to see over here, or do we need to do the reflexes over here? Y'all good? Everybody's good? And then the clonus is, if I'm doing this, I twist her leg and pull back, and her foot will go like that on a positive clonus. So you can YouTube it and see. You can go get something out of my pocket. Yay. Okay, so deep tendons are hyperreflexic. Her blood pressure is 110 over 75. Contractions are strong, irregular, occurring 3 to 10 minutes, lasting 90 seconds. What do your findings mean, and what do you do about them? She's hyperreflexive.
She
So
might
what do
have
I need to do?
Call the doctor.
She might have.
Not yet.
You need to figure out what her normal blood pressure is.
You need to figure out what her normal blood pressure is.
But could it be
So-
like because she's in pain?
Could be.
I mean, she's in
It
labor.
could be, but we don't want to ignore it. But you're right. That could be. And so if it was just that blood pressure and it was high, then
Well,
I'm not
she
going
has
to just
the
call it that. But what
hyperreflexive.
else am I going to ask her? Miss Sim Mom?
How do you feel?
Huh? How do you feel? Like what?
Are you there in the
Are you in any
Do you have a
pain?
headache? I can guarantee she's in pain, but
Oh.
do you have a headache? We want to identify, does she have a headache? What else?
Does your head feel weird?
Caffeine?
Do you feel weird? What's that?
Caffeine?
Not necessarily, because, I mean, she's 8 centimeters. I doubt that she's even really had anything
So
to
really,
eat.
you're just trying to see if she has preeclampsia.
Can you ask about
Right, so what are the other signs of preeclampsia?
nausea?
Could be
Swelling.
swelling. So what am I going to do?
Check her?
Check her pulse.
I'm
I
going
mean
to
her.
go check and see if she has pitting edema. Okay? Now, am I going to kind of expect pitting edema here? Why? Because she has a big belly that affects her circulation here. But what if I have pitting edema here? Oh, that's
Where at? Where
Where are
you
you
touching?
touching?
her arm. Or I'm going to say, right, have you noticed that you're having a lot of swelling? Is it in your hands and your face? And then I can ask her husband, does she look swollen to you? Truly, because he will know.
Well, he might
If
say
she
no
looks-
because he doesn't want to make her mad.
Right, but, does she look puffy to you? How about that? So again,
My husband would be like,
edema in the upper extremities is much more important because again, we're having
Have they started her IV yet?
not yet,
Okay.
not yet. So if she has more than 2 symptoms, then we do want to notify the doctor. Okay, so now whoever said we're going to notify the doctor now if she has that. But again, we're going to put on her fetal monitor, make sure that we're monitoring her. Are we going to do an external monitor or an internal monitor? And how do you decide?
External.
Why? It's less
Yeah.
invasive. There is one big reason why I cannot
Infection.
put an internal on her. Her membranes are intact. I can't break somebody's water.
The doctor
I
has to.
can't. I cannot. Now, have I ever done a vaginal exam and the water break in my hand? Absolutely. But I cannot purposely break somebody's water. Okay? So she's intact. I can't put an internal on. I'm putting an external. Remember, that's ultrasound. And I need to know where the fetal position is. So if she was hopefully ROA or ROP, let's say ROA, ROA, where's fetal heart tones going to be?
right side.
Right? What?
Lower.
Right lower abdomen. Okay? So I'm going to put my fetal monitor here. I guarantee that that's where I'm going to find it. Okay? So, fetal heart tones and then my contraction monitor. Remember, your contraction monitor is a pressure button. That's it. So if I put a lot of pressure on it, when I apply it, the pressure is going to be high and my contraction is going to look like they're high, the baseline. So again, I have to make sure that the machine, I can zero it out. So, because we do have to make sure that we're not having a patient overstimulate, okay? It's more important when we're inducing and forcing them to have contractions. Less bad things happen, it's not even a way to put it, when someone's actually in labor. It's just that more often, women don't go in labor anymore. We make it happen, okay? We do a lot of inductions, so inductions then cause
Infections. and-
other issues, like overstimulation to the uterus, blah, blah, blah. Okay, so We're assessing for pain.
Oh,
She has a
headache.
throbbing, huh?
Headache.
Headache, there you go. An extreme back pain with contractions. What else are you going to investigate? We kind of went over that already. Jump the gun. You are given an order for pain medicine by IV. Wait. You're given an order for pain medicine by IV till she is ready for the other medication. Because guess what happens? And this is why very often if you come in and you're 10 centimeters or you decide and you're 9 centimeters or 10 centimeters that you want an epidural, it won't happen because you have to be preloaded. Because what happens with an epidural is that the medication, if it gets in the system, can cause vasodilation, okay?
To drop.
And what happens with
Drop in
vasodilation?
blood pressure.
Your blood pressure drops. So what we do is we preload them with fluid so that if they have a drop in blood pressure, it's not going to go too low, that it's going to cause a problem with the baby. So you have to have 1,000 cc's at least of fluid before you get an IV. Before you get an epidural.
That's probably why.
So again, let's add 10, 15 minutes to starting the IV, drawing blood. The other thing is an anesthesiologist will not touch your patient without a certain blood test being done.
Platelets.
Very good. Why?
Bleed out.
Especially because it's not so much bleed, but once they go into the epidural space, if they happen to tap into the spinal space, it's not going to clot. And you're going to lose all your spinal fluid.
Then you're paralyzed.
Not necessarily paralyzed, but it's going to cause you a severe headache, and obviously you need your cerebral spinal fluid. Okay? So low platelet is a contraindication to an epidural. So guess what? You've been waiting 9 months to get that epidural and you find out you have low platelets, which goes along sometimes with preeclampsia and HELLP syndrome, which again, you can't have an epidural.
If they put the epidural in the wrong state, like in the wrong spot, could it cause a delay in it to work?
So if they don't put it in the epidural space and they put it in the tissue, it's never going to work. If they put it in the spinal, it's going to work faster and could potentially, depending on how much they put in. But you shouldn't thread a catheter into the spinal space because you're going to cause nerve damage.
I have
Okay.
scoliosis, so I got my epidural at 8 centimeters, but by the time he got it in, I guess because he had a hard time finding my space because of my scoliosis, it didn't kick in until after I had him.
Right.
Oh, no.
I want you to know that depending on how much medicine and all that and the placement, in order for an epidural to work, the medicine's put in the epidural space, but that's not where the nerves live. So it doesn't do anything in the epidural space. It's got to get through the tissue to the spinal space to seep in, so you can see someone who maybe has some scar tissue between the epidural and spinal space. It might not seep in as fast, okay? As well as it takes a while for it to get through that to get to the nerves in the spinal space. That's why if you put the medicine in the spinal space, you go numb. But if you put it in the epidural space, it's got to go through the tissue to get to the spinal space to numb your nerves. Because you know it's just numbing nerves, right? The medication is just to numb the nerves. So, a spinal is fast, an epidural is slow, but we can't continuously feed a spinal.
Yeah.
So that's why we give epidurals for labor and spinals for C-section. And if you have a really great anesthesiologist, he'll do a combo where before he does your epidural, he'll give you a little bit of spinal and then come back, thread your catheter, and continuously infuse. So that side effect of the low blood pressure is going to happen how quick in a spinal?
Fast.
Fast. In an epidural?
Slow.
10 minutes. At least 10 minutes. And then as the medicine builds up, it could get worse for at least probably another 5 or 10 minutes. So
Just stop working.
the epidural?
Yep.
Either the catheter could be kinked or something. It's just not getting through. It could be placement.
Mine worked for 4 hours and then it stopped and they came and they dished it up 4 times. None of the anesthesiologists.
It may have backed out too far.
I
think it backed
moved
out.
the whole entire time because I could still feel my feet. I positioned myself, the nurse never positioned me. It pulled out of my back.
I think so too. It probably
Yeah,
backed out.
because the
and it was going
anesthesiologist
in
came the
and
next day to
tissue.
take the catheter out of my back and he said it's not even in.
Yeah,
So I felt the full.
yeah, that's what I was gonna say, probably backed out. Uh-huh.
Can it hurt the baby?
So the problem with preeclampsia is this spasticity. If mom seizes, the uterus is not a vital organ. So blood flow ceases to the uterus, and usually the baby dies, unless they get him out quick. Okay, so it's the seizure, it's the eclampsia that becomes a problem. Okay? And so again, we preload her. What pain medicine might we give her in the meantime? Huh? So there's a lot of, Stadol is usually the safest because it usually is safe an hour after giving for the baby to be born. Okay? Because the problem with giving Stadol to any narcotic too close to delivery is the baby gets it too. So you're resuscitating the newborn at delivery if you've given Stadol, Demerol, any of those within an hour of delivery. Okay? So that's when you're going to then give the baby Narcan. Okay? For the epidural, if the blood pressure drops, what do we anticipate? What medication do we anticipate that we're going to give? So I told you what causes the drop in blood pressure? Huh? No, because Narcan is really just going to reverse systemic effects of a narcotic. Close.
That's the only one we can. No, there's another one. I just can't think of the name of it.
What's a medication that will reverse vasodilation?
No.
What medication will help constrict the vessels? Ephedrine. Epi. Epi is a vasoconstrictor. Good job. So we're going to anticipate that we're going to treat her drop in blood pressure. Anesthesia actually is going to have to come and do it. But because we can give her all the fluids we want, but the problem is then we're just overloading her with fluids, which could then be a problem because she's already have a lot of fluid on board. The only thing that is going to bring her blood pressure back up is ephedrine. Okay? So we're going to give epi to bring up her blood pressure. Okay? Or we're going to anticipate it being given.
How do you
We're going to take a break.
How do you spell the full?
The what?
The effect of whatever you said.
Yeah.
Just put epi and you can look it up.
I'm a horrible speller.
Okay? It's ephedrine.
What did she say about that? Why they have to have the fluid, the preload?